Good afternoon, everyone. My name is Kate Carr, and I'm the CEO of Cure, and I want to thank you for joining us today for our webinar. As you know, November is Epilepsy Awareness Month, and Cure is pleased to present the fourth in a series of 5 webinars that highlight key research in the field of epilepsy. Today's webinar, which is sponsored by Synovian, will focus on post-traumatic epilepsy and will be presented by Dr. Ramon Diaz-Aristea. Our Leaders in Epilepsy Research webinar series will conclude next week on November 29th as Dr. Elizabeth Donner from the University of Toronto will present on sudden unexpected death in epilepsy, or SUDEP. That webinar will also take place at 2 p.m. Eastern, and that's just a that's just a little highlight for you to flag that time if you're able to join us. Cure's mission is to identify and fund cutting-edge research in search of a cure for epilepsy. We have been instrumental in advancing the science in many areas of epilepsy research, including SUDEP, infantile spasms, devices and technology, and epilepsy genetics. Today's focus is on acquired epilepsy, specifically those who have developed epilepsy as a result of a head trauma or brain injury. Cure recently launched a new project funded by a grant from the U.S. Department of Defense that supports a team science approach to the understanding of post-traumatic epilepsy. Now, I'd like to introduce you to our expert for today's webinar. Dr. Diaz-Aristea is Professor of Neurology at the University of Pennsylvania Perelman School of Medicine. At Penn, he serves as the Director of Clinical Traumatic Brain Injury Research and Associate Director of the Penn Center for Brain Injury and Repair. His research interests have been focused on understanding the molecular, cellular, and tissue-level mechanisms of trauma-induced neuroregeneration and injury-related synaptic plasticity, with the goal of developing effective therapies. Dr. Diaz-Aristea received his MD and PhD degrees at Baylor College of Medicine in 1988, and after an internship at Beth Israel Hospital and the Harvard Medical School, he trained in neurology at Columbia Presbyterian Medical Center. He has published over 170 primary research projects, as well as over 40 invited reviews and book chapters. He's also served on several national committees related to traumatic brain injury and post-traumatic epilepsy, convened by the Institute of Medicine, the National Institute of Neurological Disorders and Stroke, the National Institute of Aging, the Department of Defense, and the Veterans Administration. As you can tell from this introduction, we truly have an esteemed expert who is bringing you this presentation today. Before Dr. Diaz-Aristea begins, I'd like to encourage everyone to ask questions. You may submit your questions anytime during the presentation by typing them into the Questions tab of the GoToWebinar control panel. Click and press Send. My colleague from Cure, Brandon, will read them aloud during the Q&A portion of the webinar. We do want this webinar to be as interactive and informative as possible. However, we do have a request. To respect everyone's privacy, we ask that you make your questions general and not specific to your own epilepsy or to a loved one's. I also want to mention that today's webinar, as well as the entire series, will be recorded and available on the Cure website. Now, let me turn this over to today's presenter, Dr. Diaz-Aristea.
Well, thank you very much, Kate, for that very, very nice introduction, and thanks for putting together this terrific series of presentations. So let me start by letting everyone know, let me see here if I can get to the first slide, in a historical note, and I want to make the point here that traumatic brain injury is probably among the oldest maladies that has affected humankind. In fact, before we were humans, we were already bashing each other in the head. There is evidence of a South African Australopithecine skeleton, a 3-million-year-old skull, that this particular individual appears to have been killed as a result of an assault by another Australopithecine that hit him over the head with an antelope humerus. And in fact, the Edwin Smith Surgical Papyrus, which is the oldest medical text, provides a very clear description of a traumatic brain injury sustained during wartime with contralateral paralysis and coma. There's been some scientific work trying to quantify this prevalence of traumatic brain injury during prehistoric times. And in physical anthropologists who have studied ancient burial sites find that anywhere from 15 to as much as 40% of all skulls found in these ancient burial sites have evidence of skull fractures, and in many cases healed skull fractures that that people survived, and in many cases survived for many years. So it's very clear that traumatic brain injury was an important factor, an important selective factor in human evolution. And any genes that would have predisposed to promoting resilience from a brain injury or promoting repair and regeneration after a brain injury were probably genes that were selected for by evolution. In some ways, the way to think of post-traumatic epilepsy is that this is the price we have to pay, in a sense, in order to allow for repair and recovery after traumatic brain injury. Obviously, in the modern era, we are not constantly going over to the tribe in the next valley and attacking them and trying to bash them over the head, but traumatic brain injury remains a big problem in modern societies. In the United States, there are approximately 3 million emergency room visits per year as a consequence of traumatic brain injury. The vast majority of those are classified as mild traumatic brain injury, although that in itself is a misnomer because some of those injuries have pretty significant consequences. They're called mild because the patient is not in a coma, usually does not require admission to the hospital. Approximately 20%, though, of these 3 million emergency room visits do require admission to the hospital, and a fraction of those folks are in coma and require very aggressive and very expensive care in a neurological intensive care unit. There are approximately 50,000 fatalities due to traumatic brain injury a year in the United States. And because traumatic brain injury is primarily a disease of young people, and if they survive the acute injury, they can live for many years and, in fact, many decades, the prevalence of disability resulting from traumatic brain injury is very, very high. And the estimates are that somewhere around 2% of the U.S. population is living with disabilities resulting from a TBI, and of those, post-traumatic epilepsy is one of the common disabilities. This is, in fact, the single most common cause of death and disability in young people, meaning young people under 45. Obviously, cancer, heart disease are rare in young people under the age of 45, but in that most important stage of life, this is the stage of life when we are completing our education, when we are finding a mate, starting our family, starting our careers. During this most important stage of life, traumatic brain injury and post-traumatic epilepsy is a significant cause of disability. The costs to society are obviously very, very high. Looking at the epidemiology, looking at it from the other end of the telescope, right, in terms of how many people who have epilepsy, how frequently is that due to traumatic brain injury, in studies over the years, and this is one of the earlier studies, but this has been confirmed over and over, indicates that if you take all comers with epilepsy, about 2/3 of the time we are unable to determine what the cause is. These are the so-called idiopathic or cryptogenic cases. And obviously anything that can result in an insult to the brain can result in epilepsy down the line. And traumatic brain injury accounts for about 4 to 5% of all cases of epilepsy affecting our society. So it's not the most important cause, but it's not insignificant either. And the other thing that's important to notice is that there is a relationship to age. Early in life, developmental disorders and infections are the primary cause of epilepsy, and late in life, strokes and tumors are the most common cause of new onset epilepsy. On the other hand, in adolescents and young adults, traumatic brain injury is in fact the most common cause of new onset symptomatic epilepsy. And that reflects the epidemiology of TBI as a condition. The risk of traumatic brain injury, the risk of post-traumatic epilepsy is directly related to the severity of the injury. This is an important old study. It's still, I want to show it because it's one of the most important studies out there. This is from the Rochester, Minnesota, the Olmsted County Epidemiology Project. And individuals who have a severe traumatic brain injury, in this top line here, severe traumatic brain injury is defined as anyone who was in a coma for longer than 24 hours or who required a neurosurgical intervention to treat their traumatic brain injury. Individuals who've had a traumatic brain injury are approximately at about a 20-fold increased risk of developing epilepsy compared to the general population. And the cumulative probability of developing post-traumatic epilepsy approaches 15 to 20%. Individuals who have suffered a moderate brain injury, which is this middle line here, well, their risk of epilepsy, of post-traumatic epilepsy, is lower, but it is still significantly higher than in the general population. It's approximately a 3 to 4-fold increased risk over the general population. And then finally, that group of people who have suffered a mild traumatic brain injury, well, they are probably at a somewhat slightly increased risk as well. Looking at the actual numbers from that study, as you can see here, about a 17-fold increased risk for severe TBI, about a 3-fold increased risk for moderate TBI. For mild traumatic brain injury, the point prevalence, the point estimate for the incidence ratio is only 1.5. Now, this was not quite statistically significant. The confidence interval approached 1. However, a more recent study using epidemiologic data from the Veterans Administration, and this is looking at administrative databases, largely confirmed the results of that earlier civilian study in Olmsted County, but because it's a much larger study, it does in fact show with statistical confidence that mild traumatic brain injury does in fact increase the risk of post-traumatic epilepsy, although only modestly, only somewhere in the range of 1.4, 1.6 to 2-fold or so. So this gives us an idea of the problem we're dealing with. Now, because mild traumatic brain injury is so much more common than moderate to severe traumatic brain injury, it actually accounts for a disproportionate fraction of the population attributable risk. This is extrapolating from numbers from the VA epidemiology study, knowing what the fraction of all TBI falls into each severity bin, as well as the odds ratio for each severity. The estimates are that almost 60% of all post-traumatic epilepsy is due to mild traumatic brain injury, whereas obviously smaller numbers for both moderate and severe TBI. So this is a really important number to realize, and this is an understudied population, right? What is the mechanism of post-traumatic epilepsy in these folks with mild traumatic brain injury? Now, because the traumatic brain injury, the precipitating event is usually very obvious, right? Most of us know exactly when someone's involved in a car accident or in a fall or an assault. So the precipitating events that ends up causing the epilepsy is usually very easily recognized and very clear. Post-traumatic epilepsy represents perhaps the ideal model in which to study the mechanisms of epileptogenesis and also to develop therapies to try to prevent epilepsy, therapies that are truly anti-epileptogenic. And that has been an effort that has gone back really many decades. And really going back to the 1980s, there were efforts trying to determine if prophylactic use of anti-epileptic drugs were effective in preventing the development of epilepsy, or were effective in preventing as anti-epileptogenic drugs. And the answer, unfortunately, is no, right? Those studies showed, and I'll show you some of the data, is that while prophylactic use of anti-epileptic drugs prevent the early seizures after a brain injury, they are not effective in preventing late post-traumatic seizures or preventing late post-traumatic epilepsy. So this is a figure from a very important study published by Dr. Nancy Temkin and colleagues from the University of Washington. Again, many decades old, but still a very important study, and it shows very clearly, and this is a randomized controlled trial, that individuals randomized to phenytoin therapy had a much lower number of seizures within the first 7 days compared to placebo. And based on this study, it is a standard practice in most neurological ICUs and most trauma centers to use prophylactic anti-epileptic drugs. Phenytoin was used for many, many years. Now, the more commonly used drug is levetiracetam. On the other hand, the study by Temkin et al., and the way the study was designed, the patients were randomized to either placebo or phenytoin for 6 months, and then at 6 months, if they had had no seizures, the anti-epileptic drugs were weaned off, and they were followed for a total of 24 months. And what you can see from this slide is that although there is a clear benefit within the first 7 days, that benefit wears off, and certainly by 24 months, there was no difference between the phenytoin and the placebo group in terms of the likelihood of developing late post-traumatic seizures. And that appears to be the case also with other drugs that have been tested, including valproic acid and phenobarbital. So the answer is that we do not have an anti-epileptogenic therapy, and clearly would very much like to develop one, and post-traumatic epilepsy is one of the potentially good models to study that. So how are we going to ever get to that point of developing anti-epileptogenic therapies, something that we could give to someone after a traumatic brain injury, or potentially after a febrile seizure, or after an episode of viral encephalitis or bacterial meningitis, with the goal of preventing the development of epilepsy down the line? So in order to do that, we're going to have to understand the mechanisms by which the injury affects synaptic plasticity and recovery. And trauma is a good way by which to try to understand those mechanisms. In general, brain injury results in both focal and diffuse injury to the central nervous system, and really either can result in epileptogenesis. Focal injury results in a contusion, hemorrhage, infarction, necrosis, and resulting in a cortical scar. And this is an example from a patient we took care of years ago, who, as you can see, had suffered a traumatic brain injury, has this scar, this area of encephalomalacia in the right frontal lobe, and he had seizures coming from this area. And we know that because this patient underwent an operation, and removing this epileptogenic zone was able to make him seizure-free, right? So that is clearly one mechanism by which post-traumatic epilepsy can establish itself. On the other hand, in addition to focal insults, traumatic brain injury also has diffuse mechanisms, and these result as a result of axonal shear injury, microvascular injury, release of inflammatory mediators, and release of free radicals. And these produces not a focal scar, but rather damage to vulnerable neuronal structures and vulnerable white matter tracts. And this is again an example of another patient we took care of several years ago. And as you can see, this young man had a severe traumatic brain injury. He was in a coma for approximately a week, and then he developed epilepsy approximately 1 year later. His MRI, the key abnormality was that there was atrophy and gliosis in the right hippocampus, as you can see here. And again, we know that that's where his seizures were coming from because he underwent surgery. He underwent an anterior temporal lobectomy, and he became seizure-free after that. So those are observations, and a couple of years ago, we published a paper summarizing the experience from our center. This is the University of Texas Southwestern in Dallas, which was, we looked at approximately 10 years worth of experience from a single epilepsy center. Approximately 4% of the patients that were evaluated in our EMU at the time met the inclusion criteria for post-traumatic epilepsy. And that is roughly comparable to the data from the Rochester Epidemiology Project, so we think that's a reasonable number. The average age at injury was 20 years, and that's again reflecting the epidemiology of TBI. It's primarily a disease of young people, in fact, primarily a disease of young men. The average age at evaluation, though, was almost 20 years later. The latency, the time that it took from injury to developing epilepsy, the median was 1 year, but it was a highly skewed distribution, so the average was really 3.5 years. So these folks had epilepsy for an average of 20 years before they were referred for EEG monitoring and an inpatient EMU evaluation. The duration of monitoring was just short of a week, and we were able to make the diagnosis in the vast majority of cases. And we found several patterns, right? Some patients had epilepsy resulting from a lesional frontal lobe injury. We also had mesial temporal sclerosis. We also had lesional temporal lobe injuries. And looking overall, approximately a quarter, or actually approximately a quarter of the patients had mesial temporal sclerosis as the etiology, or in a sense as the mechanism of their traumatic brain injury. That was considered, at the time this was initially published, this was considered controversial, but this has since been confirmed by other groups. Almost half of them, just under half of them, had neocortical lesions, but approximately another quarter were non-lesional. These are cases in whom the MRI, at least the MRI that was being done at the time, did not reveal any focal or even any diffuse lesions, but nonetheless, the patients develop epilepsy, and these are probably due to some of those diffuse mechanisms. We also had a few cases, not a large number, where the epilepsy syndrome that was noted after trauma was that of a generalized epilepsy, either idiopathic or symptomatic, and not totally sure what to make of this as the numbers were low, but it is likely that trauma may unmask a genetic predisposition to having epilepsy. That this is something that needs obviously further study, but the vast majority of cases clearly were focal epilepsies. Again, I mentioned that our initial observation of the high frequency, relatively high frequency, about 25% of hippocampal sclerosis occurring as a consequence of trauma, that was initially controversial, but it has since been confirmed by other groups, including our colleagues at University of California, Los Angeles, where they looked at their surgical series and of approximately 200 consecutive temporal lobectomies. They found 21 cases of post-traumatic epilepsy, and they found 50% of those had hippocampal sclerosis. So I think it is pretty well accepted now that in at least some cases of post-traumatic epilepsy, the mechanism of the epilepsy is hippocampal sclerosis. Now, another concept that has become clear over the last several years is that properly chosen cases of post-traumatic epilepsy can be treated successfully with surgical therapy. And in our center, we found that the cases of post-traumatic epilepsy that were found to be appropriate surgical candidates and underwent surgery, the outcomes were roughly comparable to all the other surgical cases that we were doing at the time. Approximately 60% ended up being Engle Class 1, another 20% or so ended up being Engle Class 2, So roughly 80% had a favorable outcome resulting from epilepsy surgery. And likewise, that was totally dependent on the epilepsy syndrome that they had, right? Those that had mesial temporal sclerosis as the epilepsy syndrome had approximately a 92% class 1 and 2 outcome. Obviously, the lesional cases were somewhat less favorable, the frontals less so than the temporals, and unfortunately, the non-lesional cases, we only had 2 of those, the outcome was less favorable. So I think the message is that even if the mechanism of epilepsy is brain trauma, one should still consider a surgical option, because some fraction of the time they will be, these folks will be found to be appropriate surgical candidates, and surgical therapy is certainly going to be useful and a effective therapy for some of those patients. A similar kind of result was also been reported by our colleagues in the Mayo Clinic. However, what we would clearly like is some kind of medical therapy that would prevent the epileptogenic process, that would block whatever aberrant synaptic plasticity is occurring that could result in epilepsy in post-traumatic epilepsy. And to do that, we've done some studies looking at early MRI to see if that gives us a clue as to what the mechanism of epilepsy may be. So in this particular study, we did diffusion-weighted MRI in approximately 70 patients with acute TBI. They were all scanned within 1 week of injury. And what we found is in approximately a quarter of cases, there was hippocampal damage that was noted in these early MRIs on both flares, you can see here, as well as diffusion-weighted imaging. Our colleagues at UCLA, and this is a paper published by Paul Vespa several years ago, had found a very similar thing, and in their series, they had one patient that they had the opportunity to obtain a PET scan while they were in coma in the ICU, and in fact, they found that this area of flare and diffusion-weighted abnormality corresponded with a hotspot in the PET scanner, indicating that this patient likely was experiencing a subclinical seizure at the time of the PET scan, and that corresponding to this diffusion-weighted abnormality. And in that same paper, Dr. Vespa showed that in those patients that had seizures during their ICU stay in the first several days after injury, there was atrophy of the hippocampus ipsilateral to the seizure, and that could be a mechanism by which a subset of these people went on to develop late post-traumatic epilepsy. Now, what is the mechanism for that? And again, in our studies, using a technique called diffusion tensor imaging, which allows very high-resolution analysis of the white matter tracts in the brain, we found that the white matter tracts that are afferent and efferent into the hippocampus are particularly sensitive to the shearing and stretching forces that occur after TBI. And as you can see here, this is a study showing lesions in the perforant path, in this case in the left perforant path in this patient, and that's an afferent structure into the hippocampus. And this is one patient that we had the opportunity to study. As you can see here, there's tractography of the perforant path. This particular patient had, as you can see, dropout of the axonal integrity in the left perforant path, and that was associated with the development of left hippocampal atrophy and left hippocampal epilepsy in this particular individual. So the conclusion of this kind of work is that, at least in some cases, the mechanism of epileptogenesis after trauma is resulting from a deafferentation, in a sense of a disconnection of the hippocampus from the longer-term synaptic connections, and that is responsible for the epileptogenesis that develops over time. Another possible mechanism, and this is just something that we've started studying more recently, is that trauma results in breakdown of the blood-brain barrier that can be subtle but can also persist for many months or many years. And that breakdown of the blood-brain barrier may result in local inflammation, release of inflammatory mediators into the brain, and that can result in epileptogenesis down the line. So in conclusion, I want to make the case, I hope I've shown you, that post-traumatic epilepsy is phenotypically heterogeneous in humans, and that we have to understand that phenotypic heterogeneity in order to have a chance of developing anti-epileptogenic drugs. Both focal and diffuse mechanisms can result in post-traumatic epilepsy. Somewhere between 25 and 30% of intractable epilepsy after TBI is associated with mesial temporal sclerosis. Surgical therapy is a viable option in appropriately selected cases, and that these kinds of studies and our future goal is to understand the mechanisms of epileptogenesis after TBI, which will help us identify and develop and validate effective therapeutic strategies that will prevent not only post-traumatic epilepsy, but potentially have a role in preventing future cases of other symptomatic epilepsies. So that was my last slide. I hope that I have not gone over too much over time, and I'd be happy to entertain some questions.
Thank you, Dr. Diaz-Aristea. That was a wonderful presentation. We'll now begin the Q&A session. Again, if you have any questions, please type them in to the Questions tab of the GoToWebinar control panel and click Send. And I think we're going to start with Brandon leading us in some questions. So.
Sure. First question, Dr. Diaz-Aristea. What strategies may be developed to help prevent post-traumatic epilepsy?
Well, through our work on understanding the mechanisms, I think point to some strategies that may be very attractive. So I do think we now know that anti-epileptic drugs are not epileptogenic necessarily, and we rather need drugs that are going to promote the integrity of the axonal connections into the hippocampus. We may also need drugs that promote the repair of the blood-brain barrier and perhaps block some of the long-acting or long-duration inflammation that occurs in the brain. So the goal of developing or the mechanism of developing anti-epileptogenic drugs is really going to be tied in to these strategies to promote the integrity of resilience and recovery of these particular neural structures.
Great, thank you. Next question is, if you have decades of seizures and epilepsy and you've had multiple brain surgeries, would you say that you have a brain injury, or would it be, would you say that you have a brain injury? Would that be an accurate statement? Obviously it's not a TBI, but would you call it an ABI?
Well, I mean, of course. I mean, I think obviously epilepsy can occur from many different consequences, but certainly anything that injures the brain, be it a traumatic insult to the head, or be it an ischemic insult, or an inflammatory insult, or an infectious insult, can result in epilepsy. Now, many cases of epilepsy, such an insult is not recognized, which is not to say that it wasn't there, right? It may have been a subclinical or a subtle insult, but nonetheless resulted in an injury. So no, I do think the answer to the question is right, that in most cases epilepsy does result from some kind of injury, and that discovering how that happens is potentially of value in preventing the development of epilepsy, and also potentially treating the seizures after it already developed.
Next question. Are there specific symptoms that indicate if epilepsy is due to a brain injury as compared to other epilepsy causes?
Well, most patients who develop epilepsy after brain injury develop a focal epilepsy syndrome, although it can be anywhere in the brain, right? It turns out that temporal lobe epilepsies appear to be the most common. There is something about the temporal lobes, particularly the mesial temporal structures, that make it uniquely pro-epileptogenic, but we certainly can have frontal lobe epilepsy, parietal lobe epilepsy, occipital lobe epilepsy. It can start from anywhere where there's an injury, and the manifestations of the seizure obviously depends on where in the brain the seizure is starting. So the manifestations of a frontal lobe seizure are going to be different from those from a temporal lobe seizure or an occipital lobe seizure. So it's the kind of stuff that requires careful evaluation, and in most cases require admission to an epilepsy monitoring unit for video EEG monitoring. But yes, one can have one can determine what kinds of epilepsy develops from what.
Thank you. Next question, we have a question about veterans and the prevalence of post-traumatic epilepsy in the veteran population to other types of populations with head trauma.
Well, veterans are at a particularly high risk of suffering traumatic brain injury, and this is a consequence of their military service, but it's not only, I mean, veterans or military personnel are at high risk of traumatic brain injury, obviously in combat settings, but even during practice or during training and just living in a harsh environment is risky to and there's a high incidence of brain injuries from that. Brain injuries are very common in the general population, but individuals who have served in the armed forces are at approximately a 3- to 4-fold increased risk of developing, of having a brain injury and a correspondingly increased risk of developing post-traumatic epilepsy. So this is a major problem to the Department of Defense, military health system, as well as for the Veterans Administration health system. And a lot of the research in this area historically has been funded by the DoD and the VA.
Great, thank you. Do you happen to know the percentage or approximate percentage of post-traumatic epilepsy patients that are candidates for brain surgery?
Well, unfortunately, that's a very hard number to know. It's certainly not the majority, but it could be as much as 10–20%. And I think everyone who has epilepsy that is refractory to medications, which means that they have been on good doses of at least 2 anti-epileptic medicines and they continue to have frequent disabling seizures, that is someone who, regardless of the etiology of their epilepsy, regardless of the cause of their epilepsy, should be referred to for epilepsy monitoring unit admission and video EEG monitoring to determine if they are surgical candidates. I think surgery remains an underutilized therapy option in post-traumatic epilepsy as well as in many other causes of focal epilepsy.
Thank you. Next question. What are your thoughts about the predisposition to Alzheimer's after one has had a closed head traumatic brain injury?
Well, I think this is another area where my laboratory is very busy in investigating. So it appears that individuals who sustain a moderate to severe traumatic brain injury are at greater risk of developing late life dementia. And that risk is somewhere in the order of about 3- to 4-fold for severe traumatic brain injury. But that even mild traumatic brain injury increases risk of late life dementia modestly, but probably by around 30 to 50%. Now that doesn't sound like much. On the other hand, given that late life dementia is so common, even a modest increase in relative risk does translate into a large number of cases. Now, whether that dementia is Alzheimer's disease or whether it is some other kind of late life dementia, that remains to be proven, right? And again, that's one of the things that we very much need to investigate, is if we can identify what is the mechanism of that risk of late life dementia after a TBI, what can be done to prevent it? Do we have any strategies that could help in promoting the resilience or promoting the recovery of the brain after brain injury, and we just don't know yet, but it's an area of very active research.
Great, thank you. The next few questions have to do with drug or therapeutics and drug therapies. Do you feel that there is an ideal anti-epileptogenic drug profile?
Well, the ideal anti-epileptogenic drug profile is one that controls the seizures 100% and doesn't produce significant side effects, right? Now, that ideal drug is going to be different for every patient, right? But many patients are able to find a drug or drug combinations that is ideal for them, meaning that it controls their seizures and allows them to continue their life without significant side effects. Unfortunately, that only happens about 60% of the time. So that is a significant number of people, and the drugs, many of the drugs that we have are good drugs, but that remains that about 40% of patients with epilepsy, and that includes post-traumatic epilepsy as well as other causes, are unable to find an ideal drug or drug combination that works for them, and that remains a big problem, which certainly stimulates our work in the area, trying to develop preventative therapies and also trying to develop better symptomatic therapies.
And what about starting a ketogenic diet post-TBI as a possible seizure prevention protocol?
Well, I mean, I think that's a potentially good strategy, right? There are some work, primarily so far in animal models, that a ketogenic diet appears to be neuroprotective, appears to prevent the death of neurons and some of the aberrant synaptic plasticity. Research in this area is very, very early, I must say, and it's so far mainly in animal models, but it certainly looks promising. Not an unreasonable approach to try.
And what about research in the space dealing with devices such as brain cooling?
Well, so likewise, in animal models, there is very good evidence that cooling the brain soon after the injury prevents the development of post-traumatic epilepsy, and in fact helps in preserving neural structures and preventing preventing neurodegeneration. So I think that is likewise an attractive strategy. So far, it's really only been tried in preclinical models. It appears that focal brain cooling is what's important. There have been several studies in patients with TBI doing whole body cooling, and that does not appear to work as well, and it's mainly because cooling can have deleterious effects on pulmonary function and cardiac function and renal function, and but focal brain cooling is certainly a promising strategy.
Now, do you feel that preventing hippocampal neurogenesis after TBI is a viable therapeutic direction for preventing mesial temporal lobe epilepsy?
Well, gosh, that's a very loaded question. So there is neurogenesis in the hippocampus after TBI. In most cases, that is a good thing because that allows the recovery of memory function and attention and things that the hippocampus does. So I think one would have to be very, very careful about a strategy where one tries to prevent the normal healing pathway. On the other hand, it is likely that as I mentioned earlier in my talk, that post-traumatic epilepsy may result from those attempts of the tissue to rewire and repair itself. That some of those reparative processes may not be totally perfect and result in a circuit that is epileptogenic. So I would say that one has to be very careful and one has to be very precise on strategies such as this, and obviously develop strategies that target the aberrant neurogenesis and the aberrant synaptogenesis while leaving the neurogenesis and synaptogenesis that are important for recovery in place.
Great, thank you. Another therapeutic question: Are sodium channel blockers therapeutic in post-traumatic epilepsy?
Well, I mean, so dilantin, for example, is a sodium channel blocker, and it does not appear to be effective, although it blocks the early seizures, does not appear to be effective in an as an anti-epileptogenic agent. So, I would say that although not every sodium channel blocker has been tested, more likely we are going to need alternate strategies to come up with a truly anti-epileptogenic compound. And those alternate strategies are going to have to rely on things like blocking inflammation, or promoting repair of the blood-brain barrier, or perhaps promoting integrity of the axonal pathways that become disconnected. I'm personally not that hopeful that just because a drug is anti-epileptic, that it will be anti-epileptogenic. I think the data we have so far seems to indicate that that's not the case.
Thank you. Next question: Are there any specific group of neurons implicated in post-traumatic epilepsy?
Well, I think that there's not any one specific group. I think that depends a lot on the location. I think what tends to happen, right, is that when you have a brain injury, many neurons are lost and are damaged, and then the neurons that remain attempt to rewire in order to repair the function of the circuit. But that rewiring is sometimes not perfect, and that's how an epileptic circuit presents itself. So it appears to be mostly the neurons that are relatively resilient to injury that may be responsible. And again, I think it's a two-edged sword. You would not want to prevent epileptogenesis with a strategy that also prevents the repair and recovery. We would have to be a lot more precise and a lot more clever to come up with strategies that prevent the aberrant synaptic plasticity while allowing the functional or the positive synaptic plasticity to persist.
Great, thank you. Can seizure type after a traumatic brain injury be a basis for predicting the risk of reoccurrence?
Well, that's I don't think we know the answer to that yet, right? I think what very frequently happens, that it often takes a while for the diagnosis of post-traumatic epilepsy to be made. And when we talk to patients who have developed epilepsy after a brain injury, in reality, they often have subtle behavioral problems or subtle memory problems that precede the development of clinically apparent seizures. And in retrospect, those were probably very small, very focal seizures that were occurring before the clinically apparent seizures presented themselves. So I think the answer is that we're really going to need strategies that allow the diagnosis of post-traumatic seizures very early on, in many cases before it's very clinically apparent, in order to develop effective therapies.
Great, thank you. We've come to the end of our audience questions, so I'm going to go ahead and turn it back over to Kate.
Thank you to our audience. I want to say you've been really tremendously engaged with great questions. And Dr. Diaz-Aristea, I have a question for you. You just spoke about the need for early diagnosis so that we can get to effective treatments. May I ask, are you hopeful about the near-term future for patients with TBI?
Well, gosh, boy, that's a good question. I've been working in this field for about 25 years, and we have had great progress. On the other hand, when I started working on it, I certainly would have hoped that we would have been further ahead by now. So I have long accepted, and I've told my wife and children this, that optimism is one of my personality flaws. So I do believe that we will develop some effective anti-epileptogenic therapies before I retire, right? But that's obviously that's only a belief in terms of having very solid therapies. I do know that the amount of research in this field has skyrocketed over the last several years, and this is mainly through the support of the Department of Defense, but also through the Cure Foundation and many others. We now have much better animal models. We have much better understanding of what's going on at a cellular molecular level. We have much better biomarkers, be they imaging biomarkers or molecular biomarkers. So I do think we have the tools in place, and we certainly have some strategies that appear to be successful in animal models. Obviously, translating those into humans is not necessarily an easy or even a linear proposition. But I am an optimist, and I think the answer is that we will have something in the next 10 to 15 years or so.
Well, we thank you for your optimism and your hard work and for a wonderful presentation today. This is concluding our webinar on post-traumatic epilepsy. A special thank you in addition to Dr. Diaz-Aristea, to Synovian, our sponsor of today's webinars. If you have any questions about this topic or about Cure's research programs, you can visit our website at cureepilepsy.org or email us at info@cureepilepsy.org. You can find more information on Cure events during Epilepsy Awareness Month, and I want to make a special plug for the My Shot at Epilepsy campaign, which is, there's a link to it on our website. We really want everyone to get out there and take their shot at helping us to cure epilepsy. So a reminder again to register for our next webinar on November 28th, excuse me, next week with Dr. Elizabeth Donner from the University of Toronto. Thank you, everyone, for joining us. We have a last comment here that I will share, and it was a simple one. It was very good, and I wholeheartedly agree. This was a great webinar. Thanks, everyone. Have a happy Thanksgiving.
Thank you so much.
Thank you.